So good morning, everyone. Please take your seats if you haven't yet done so. Our second plenary, the first plenary of today, will be starting in a couple of moments. But before we start the plenary, and in case you weren't aware, I wanted to share with you some sad news, the news of Professor Doug Altman's passing yesterday. Some of you may have had the privilege of working with or meeting Professor Altman, but I'd say all of us here have been impacted by his work, even if you don't recognize that. He was a statistician extraordinaire, yet so modest too. He was best known for his work to improve the reliability and reporting of medical research, and his countless papers on statistics and statistical principles are the foundation of much of evidence-based medicine. I think it's fair to say our community and the wider evidence-based medicine community will not be the same without him. So let us honor Doug today by committing to what the quote in front of you says. To maximize the benefit to society, you need to not just do research, but to do it well. Thank you, Doug.
Thanks, Timmy. I'd like you to join with me in recognising and honouring the First Nations peoples on whose land we are privileged to meet together and learn together this morning. Tēnā koutou katoa. Good morning and welcome to this morning's session. My name's Anne Colby. I'm a practicing paediatric surgeon, and I've had the privilege over the years to interact with this community that is the circle of colleagues in HTAi. I'd like to thank you for the privilege of being invited to come and chair this second plenary session in Vancouver in 2018. This morning, we plan to leave you in the hands of what is a very special panel, which I hope you will enjoy listening to and working with. In no particular order, the people that you are going to hear from and have the opportunity to question this morning are Dr. Joshua Tapper. Joshua is the President and CEO of Health Quality Ontario, and even more importantly, he is a practicing family medicine physician. Dr. Holger Schönemann. Holger is an internal medicine specialist and a clinical epidemiologist with an interest in community care and preventive medicine. He's also the chair of the Department of Health Research, Methods, Evidence and Impact at McMaster University here in Canada. Dr. Sally Lewis. Sally is a vocationally registered and practicing general practitioner in the United Kingdom. She's also the National Clinical Lead in Wales for value-based and prudent health care. Sally is here because sadly Dame Denise Kohler is unwell and could not join us. Dame Denise is a psychiatrist. And unfortunately, also Marguerite Costa had an unfortunate accident a couple of days ago. She is recovering here in British Columbia, and I'm sure you'll join with me in sending us all her best wishes. She is unable, understandably, to join us, but we're very privileged to have on the end of the phone Dr. Joel Whittaker. Dr. Whittaker is a senior consultant in evidence-based medicine services at Kaiser Permanente in Southern California, and he has a master's degree in public health. So I've introduced the panel to you. Before we get into the business of this morning, I'd like to do two things. Can those of you in the audience who are practicing healthcare providers, please, whether you be allied health professionals, nursing professionals, or medical professionals, please stand up. Thank you. Don't sit down, stand up. So those of you who are patients or patient representatives in the room, please stand up. Anyone else? Well, I know you are, but especially patients. All right. I'd please like us to look at this group of people and remember one crucial point for this morning. The delivery of healthcare, as Richard Smith, who was mentioned yesterday, is related to the contract or the partnership or the interaction between the patient and the healthcare practitioner that that patient works with. So that combination is the end user combination of everything we do in health technology assessment and management. It is to service the interaction between the pivotal point of where healthcare is delivered. And I think you're going to hear some more about that today. The next thing I want to say is I want to ask you to remember and hold close some of the key points that we heard yesterday. You'll all have your own key points, but for me, what I heard was what constitutes evidence? And is it all clinical evidence, or is there other evidence that matters in our work? How much evidence do we need to make a decision? What's the quality of the evidence we need to make a pragmatic decision? How do we deal with uncertainty? How do we make wise decisions where there will be uncertainty? And how do we mitigate the resultant risks? And what are the costs? The costs of poor decision-making, and much more importantly, the cost of slow decision-making. I want you to think about those things, and I want you to remember the eternal quote that says, "The elegance that exists in simplicity." And consider that as we go through the morning. How's this going to work this morning? Each of the speakers is going to talk to you for 10 to 12 minutes. We will leave all questions to the end, and we are aiming to allow a lot of time for your questions and interactions with our expert speakers. So, without ado, I'm going to introduce first Joel Whittaker, and Joel is joining us from Southern California. He will be on audio link, and he will be on audio link for the entire of the plenary, so you will be able to question him as well. Josh, are you with us?
Yes, hello, this is Joel. I'm assuming
good morning,
everybody can hear
and
me,
welcome.
And if not, they'll let me know. My name is Joel Whittaker, and unfortunately, I am. You guys get the understudy for this performance of the eScope initiative. As stated, Marguerite Coster is unable to be here today with you all, so I'm doing this from Southern California. I've worked for over 16 years in the evidence-based medicine services unit here in Kaiser Permanente, Southern California, with Marguerite Coster and the evidence-based medicine services team down here. And I think what Marguerite wanted to talk to you about was the eScope initiative, which I'm one of the evidence-based medicine consultants for this project. Let's see, there we go. Before delving into the specifics of the eScope process and our initiative, we wanted to give you some of the context for what we think are some pretty impressive or staggering statistics and those are that over 251,000 registered clinical studies are ongoing worldwide. By 2018, 2019, we anticipate that there will be about 50,000 randomized controlled trials published annually. And that doesn't include the more than 8,000 systematic evidence reviews that are published annually. Pretty staggering numbers, we think. And this growth in volume of clinical research studies has been coupled with a very slow rate of adoption. Numerous studies have shown that it does take, on the average, about 17 years for new evidence-based findings to reach clinical practice. And given these large volumes, it's a challenge and really almost impossible for our chiefs of service, at least in Kaiser Permanente, our physician groups, our frontline physicians, our health plan administrators, quality improvement staff, to keep pace with and identify effective healthcare practices that warrant implementation. And so that begs the question, how can we bridge this knowledge to action gap? Our answer to this question, we think anyways, is what we call the eScope initiative. eScope stands for Evidence Scanning for Clinical and Operational Practice Efficiencies. Just a little history of how it got started. Back in 2014, our medical director of clinical quality, Dr. Michael Canner, approached our evidence-based services team and asked us to develop a system for proactively scanning newly published literature for high-quality studies, and then putting that evidence or those studies directly into the hands of our clinical decision makers, frontline physicians, leaders, who can make better, faster decisions about the implementation of these best practices to ultimately improve the effectiveness, safety, timeliness, or efficiency of care. And so eScope became a collaboration between our team of evidence-based medicine specialists or the knowledge brokers, our clinical leaders, both regional physician administrators and frontline physician leaders, our chiefs of various specialties, our eScope implementation team, which currently we have consists of 2 eScope project managers, and last but not least, collaboration with our existing clinical quality data team, which helps with evaluating or measuring the extent to which we've successfully implemented a project. At this time, we've got actually over 22 projects in various stages of implementation. So what is the eScope process? eScope, we basically break it down into 8 key steps, which we perform on a quarterly basis. In step 1, our EBM services team conducts an initial customized search of various evidence databases, repositories, pulling from high-impact journals, from each of the major specialties in our system. Typically, we scan through and pull about 1,000 abstracts per quarter in this initial dump of data. In step 2, our EBM team conducts an initial screening, wherein we select relevant abstracts. In doing so, we focus primarily on randomized controlled trials or systematic reviews of randomized controlled trials, which we feel have demonstrated moderate to high impact on important health outcomes, shown operational efficiencies, affordability, or all of the above. We try to select for studies that we think are generalizable and implementable within our KP integrated healthcare system. So typically at the end of step 2, we aim to have about 100 or 150 studies that we submit in step 3 to our clinical leaders for review. Our clinical leaders will review the 150 abstracts we've selected, and they will, in turn, select studies which they think should be distributed and shared with our frontline chiefs of various specialties and clinicians or leaders. In doing this, they consider many of the same factors we consider in step 2, but given their clinical expertise, their familiarity with what's going on in the organization in terms of what's been tried, what hasn't been tried, what's worked, what hasn't worked, they're able to further help us filter through the literature. Is this something we're doing in KP already? Does this intervention improve quality, safety, efficiency? Does it reduce costs? Again, is it feasible in our system? Those are the types of questions that they help us address. So after they've done that, we've narrowed our volume to about 50 or 70 studies per quarter. such that in step 4, we prepare to distribute the studies to our key stakeholders. We do that either via written email communications or in-person meetings. It's at this stage that we will pull the full text of the articles, if we haven't already done so, and we conduct a more rigorous appraisal of the studies, assessing things like the risk of bias if it's a single randomized trial, or if it's a systematic review, we make sure that it's methodologically sound, checking it against AmStar rubrics and that sort of thing, such that at the end of this stage, we're typically left with about 35 to 40 studies, which we think are ready for distribution to our key stakeholders. In step 5, the studies are sent to stakeholders or presented to stakeholders at various chiefs of service meetings. We solicit their feedback. Again, we ask them, is this something that we're currently doing? And if this is not something that we're doing, is this something that we should consider further for deployment? If it's essentially a fishing expedition. If they say yes, if they take the bait and say, yes, we're interested in this, it's at that point in time that we set up an initial follow-up meeting with the stakeholders and get a group together to discuss the potential benefits of implementing the practice, whether the practice is feasible in our system. In step 6, our project managers will then assemble a multidisciplinary stakeholder team that works with the physician lead or the leadership to develop an implementation plan, which is highly variable depending upon the actual intervention being evaluated in the study, the setting, the patient population, and the available resources that we have in our system. In step 7, once we've got the implementation plan in place, we continue to support the implementation of the selected practice as needed by providing oversight, facilitating meetings, troubleshooting problems. But ultimately, our goal, whenever possible, is to hand over ownership of the implementation efforts to the local stakeholder team. We don't have, with only 2 project managers on staff, including myself, we don't have the staffing to be able to hold on to all of these projects in perpetuity. And then in step 8, our final step of the ESCO process is we endeavor to, whenever possible, conduct an assessment of implementation progress. We don't seek to duplicate measurement of health outcomes per se, as much as track implementation outcomes. And I will not go into too much detail about that at this time because of our time constraint. In steps, okay, so key factors considered for new ESCO projects. When we, at each step in the process along the way, we consider various factors for whether or not something should become a new initiative. And we ask our clinical leaders of the eScope team, as well as our frontline leaders, to factor all of these into consideration. Quality of the evidence, obviously, is it high quality evidence? What is the expected benefit? Is there a large gap between the potential benefit versus potential harms in terms of this intervention that's being considered? Can it realistically be implemented in our system? Will our stakeholders, will our physicians ultimately buy in? Will we get buy-in for it? Because if we don't have buy-in from our physicians, ultimately, it doesn't get off the ground. And oftentimes, we try to provide a service to our physicians. Our physicians are asked on an annual basis to develop clinical quality goals. So many of the projects that we, or topics that we send to them may and have become clinical quality goals that are measured throughout the region. And then again, is this something that we're already doing? And then ultimately, what is the cost? What are the cost implications for this? Is this something that's way too expensive and unrealistic for us? Or is it something that, oh yeah, we could probably pull this off. We've already got the infrastructure for this. We're sort of doing this already. I think we can do it. I won't read through the various examples of interventions that we've launched to date, but I will note that, so we not only look for interventions to deploy, which have been shown to be beneficial in the published literature, but we also look for opportunities to de-implement things that the literature or the evidence has shown to not be effective any longer. For example, the example of the continuous passive motion after total knee arthroplasty. In consideration of the 17-year estimated lag between publication and implementation, we think we've done a pretty good job with regard to reducing that in our system anyways. Our mean publication to implementation launch time is run about 16 months for most of the projects that we've attempted to deploy. What are the key challenges with eScope? Definitely keeping up with the quarterly pace of the evidence searches. So given the volumes that I mentioned earlier, it's a challenge for us, but we've been doing pretty good with the quarterly pace of review. We often take for granted that our frontline physicians understand principles of evidence-based medicine and how to read a study and interpret statistics and an odds ratio or relative risk, but that's not always the case. So we find that we do have to put the evidence into context in terms that some physicians can better understand. Given the volume of inquiries that we send off on a quarterly basis, and our physicians are practicing physicians, it's not uncommon that we get a lot of unresponsive stakeholders. And so we have to be somewhat persistent, but mindful of the fact that they are practicing physicians, and so if we don't get a response initially, that sometimes we have to let it go. If we don't get a response after one or two inquiries from our physicians, we just have to let it go. Another challenge for us is initiative overload. If we've got 2 or 3 OB-GYN projects in the queue that our regional chief is working on that we've introduced, how much more can they realistically take on? So we have to be mindful of that and be careful about overload. And then I mentioned finding project ownership for projects. Our goal is to hand off projects, but there are some projects, and our physicians don't have project managers at the frontline clinic level, where we have to maintain and hold on to the projects, and if we don't, they will simply cease. So we have to balance, holding on to a project versus finding an owner for a project. And I mentioned the length of time. While we feel we've cut the time down from stakeholder agreement to the uptake and deployment of a project, things always seem to move a little more slowly than we'd like them to, or than we expect. In a big system like Kaiser, one of the challenges is also that avoiding duplicate initiatives. While we think something might be new or novel and we introduce it to a chief, and the chief might say, yes, this is something that we should look into, we have to be careful that there aren't others somewhere else in our system that are already doing it or deploying it or have attempted it. So we have to do our due diligence to make sure we're not duplicating efforts. And then I mentioned this a bit, one of the challenges is process outcomes versus health outcomes. A lot of times our physicians will say, oh yeah, this is great, we should do a study, or we should measure the impact that this has on the particular health outcome. And our response is, well, no, the study or their systematic review has already done that for us. We're not looking to duplicate the results of the randomized trial or the systematic review of randomized trials. That would be the opposite of what our intention is as part of the eScope initiative. We primarily want to focus on assessing whether or not the intervention has been implemented, and to some extent that might involve measuring health outcomes, but more often than not, we're looking at has the intervention been deployed. So that's what we focus on when we consider monitoring and measurement. I think that's it. Hopefully I didn't go over my 10 minutes, but maybe I did. I'll turn it back over to the group. Thank you.
Thank you, Joel. You did not. That was excellent. I think I heard some interesting words that we should hold on to. I heard buy-in from end users. I heard stakeholders. I heard corporate versus clinical outcomes. And I heard time to implementation. In other words, diffuse fast and or fail fast actually matters in the game we play in. Thank you ever so much, Joel. Please stay on the line. Can I please ask Holger to come and speak with us?
Thanks very much, Jan. Thanks for the introduction and thanks for the invitation. Really pleased to be here. My name is Holger Schünemann, and my presentation I'm sure will come up in just a second. I will address the issues that arise from guideline development or relate to guideline development, practice guideline development and implementation, and talk a little bit about how to shorten that gap of 17 years that Joel mentioned a bit earlier. I spent the last 20 years of my career in guideline development, and we'll try to summarize that in 10 to 12 minutes now. Okay. So I have a few disclosures to make. I direct Cochrane Canada, obviously a systematic review organization, and I co-chair the GREAT working group that will both be mentioned in this presentation. And I'm also co-chair of the European Commission Initiative on Breast Cancer and the American Society of Hematology venous thromboembolism guidelines, and that's relevant because I will speak about these two examples. For the longest time, clinicians have been asked to practice according to the principles set forth over 2,000 years ago that said to do not harm or to do no harm. And in reality, we all know that that is an unrealistic expectation. Every intervention, every test, every conversation with a patient or a care recipient has the risk of harm. And the real issue is to not do net harm. And we do that by weighing potential desirable consequences, such as the benefits of a health intervention, the related utilities of this health intervention, the related resources, and whether or not it's doable, which really stands for acceptability, feasibility, and equity considerations against the opposite. And this balance determines healthcare recommendations and healthcare decisions, obviously. The GREAT working group over the past 10 years or so, through various funded projects by the European Commission, has developed what we call GREAT evidence to decision frameworks that address this particular issue in detail. These frameworks include details about a potential healthcare question, including about subgroups, background that is required for making decisions, an assessment section that is based on specific criteria that we have evaluated that are based on other decision frameworks and include some new criteria that include judgments and are primarily based on synthesized evidence from systematic reviews and health technology assessments, followed by a conclusion section that basically includes a suggestion for a decision, could be a coverage decision or a healthcare recommendation, and it includes sections around implementation considerations, monitoring and evaluation, including research that needs to be done to fill the gap of going from evidence to implementation. And then finally, it includes presentation options that once again has to do with informing group processes. How does a group actually arrive at a decision using these frameworks? And I will speak in particular about two assets there that we have, apps that facilitate the implementation into practice on an individual level, as well as how this might work on a jurisdictional level. And GREAT has an app that is utilized to facilitate these processes called the GREAT Pro GDT app that really lets you do these type of things. I will focus on two aspects in the next 8 or 9 minutes or so, on the actual assessment of evidence and the presentation and implementation. So let's start with the assessment. This is essentially how this works. It starts with looking at the criteria that determine a decision here on the left-hand slide. How important is the problem, the priority of the actual healthcare issue, what are the benefits and harms of the potential options, how certain or what is the quality of the evidence? How certain can we be in it? The underlying values and preferences, I mentioned already, resource use, feasibility, acceptability, and obviously equity. A guideline panel would, on the basis of synthesized evidence from HTAi, or we do a lot of Cochrane reviews, describe what the incidence is, what might be the benefits based on what type of studies, how good is the evidence, so there may be moderate certainty of the evidence, what type of value information is out there, what is known about the utilities, and what type of value a guideline panel places on the individual outcomes. Is it cost effective? And then this type of information is informed by judgments by a panel that, for instance, would say, based on cost effectiveness information or evidence, the intervention is probably favored over the comparators that we are looking at. When there is no evidence, the panel would say, we don't know. But at an implementation level, the relevant people who contextualize might find local evidence to help with implementation. And then finally, there may be barriers and costs that vary across different healthcare systems, and a decision-making body, in particular a centralized decision-making body such as a guideline panel, might say, here are the things to consider, but it's clear that it varies obviously across context. And then in the typical guideline panel, or a result of a guideline panel would be in this case, a clinical recommendation. The guideline panel, as an example from these ASH guidelines, suggests using prophylactic blood thinners such as heparin in patients with solid cancers to avoid complications such as blood clots. Now, this is happening on a population level. Recommendations by a guideline panel are typically for an average patient, but unfortunately, we all know, or fortunately, there is no average patient. Every patient has his or her individual characteristics. And the big question then is how to take these decisions that are made by a guideline panel and directly translate them into personalized decisions. And the tools that I just described facilitate this process. By knowing about the judgments that the panels make, it helps with implementation into practice. So what happens in this particular arena of going from the decision criteria to an individual? Primarily on an individual level, health benefits and harms, values, and particularly resources when it's relevant in certain jurisdictions. In Canada, we are pretty fortunate. In other jurisdictions, people are not as fortunate, may play a role when we actually take this evidence and implement it. So depending on the context, these are probably the key criteria for an individual. And one way of dealing with this is through the use of interactive or any type of decision aid that many of you will have heard of. We have called this relation between guidelines and decision aids an inevitable relationship that needs to be tackled and addressed and better described. So for instance, with regards to this ASH project, the American Society of Hematology Guidelines, we are directly, based on the guideline panel's work, producing decision aids, interactive decision aids that we call ideas. And that provides background to a patient population. It provides a detailed overview of the potential benefits and harms, what the actual guideline panel is recommending for a given scenario, and that is done once again through web-based platforms or information that could be printed. It includes a value elicitation exercise in order to individualize, once again, personalize these decisions. It includes, for better communication, a description of the key outcomes that are being addressed. For instance, one of the potential side effects is bleeding when you receive a blood thinner. And in this particular effort, we paid great attention to the fact that, first of all, panel members have to agree on these outcomes. So there is a health outcome descriptor, a marker state. And the recipients of this information would have to understand that information as well. So a description of the outcome, health, a major bleeding in this particular case, would be made transparent to both the developers of a recommendation as well as those who use it. And then finally, one of the big issues to tackle is actually individualization of baseline risk. How big is the risk before you apply an intervention in an individual person? And as part of these decision aids, we are developing baseline risk estimators where patients would based on risk assessment models that are established or on available evidence, be led to or helped with individualizing baseline risks, so that at the end, an individualized risk based on the original information, both for baseline as well as for the treatment effects, can be generated that support a decision-making process by the clinician and the patient. And that can be directly derived, as I said, from these type of evidence to decision frameworks that we've developed, so that at the end, patients sit down and make their individual decision that depends on individual characteristics, and certain patients may opt to accept a recommendation and implement it. Others may say, this is not for me because my values and the actual health outcomes will be different. So decision aids. I want to turn for the remaining few minutes to an example that that describes implementation on a policy more on a population level. This is the example that I mentioned initially, the European Commission initiative on breast cancer. And this is an initiative that has started about 2.5 years ago, and it focuses on developing guidelines, recommendations for the European Commission, essentially membership countries. I'll get back to that in a second. And this is a web portal that is developed basically in real time with the recommendations being published. It addresses 3 different key stakeholders. So for instance, it provides information for patients, similar to what I just described, eventually as a decision aid, where a patient can go in and evaluate the information that is there. For instance, whether or not if you are aged 45 to 49, you should undergo or should have mammography screening. And this information then would be presented. There's information for professionals. I de-emphasize professionals today in my presentation and focus on, so healthcare professionals, clinicians, and focus on the other 2 groups. But for instance, for healthcare professionals, there would be detailed information individuals or healthcare providers can obtain, for instance, information about the evidence that supports a particular recommendation by clicking through that relevant information on this web portal. And then finally, I want to get to the policymaker. The policymaker will require a different type of information in order to say, here is a European Commission recommendation, a guideline, does that actually work in my jurisdiction? And once again, supporting information is there, but I'll get into some of the details. So what really happens on a country level with regards to implementation, and actually 35 countries are addressed by these European Commission recommendations. It's not only the EU. For instance, how relevant is that for the small country of Estonia? I don't have a pointer here, so I cannot point on both screens simultaneously, I think. So it's in the Baltic region up there. And what does that mean, a recommendation on the European Commission level for the country of Greece that doesn't have an organized mammography screening program? So what can country-level policymakers actually do? There are ways of increasing efficiency in guideline uptake, and one way of doing this is to simply adopt an existing recommendation that is offered centrally. Policymakers can adapt recommendations to their own context by looking at additional information. How well does it fit? How well does it not fit? Is the baseline risk the same in our population? Or they can say, none of this is relevant. We need to develop our own recommendations. And we are using framework for this type of approach. You can do all of that together, which we've called a development. Basically, it means looking at the recommendations and making them fit for purpose. It's an interesting paper that you can pick up in the Journal of Clinical Epidemiology. But what really does that mean with a policy lens? So with a policy lens, recommendations by a guideline panel are made for a population, in this case for women, and the policymaker really has to consider all of that because their decision will initially, at least, affect the entire population. So all of these criteria are relevant. Primarily context and resources, obviously. So these evidence to decision frameworks allow sharing through browser-based platforms. And for instance, to give you a very quick example, Estonia now is looking at implementing these European Commission guidelines and is receiving the original work based on this web-based platform that we have, the original evidence assessment with all the judgments, in order to then see whether or not that works on a country level. And primarily, for instance, cost may be relevant, or resource utilization that is indicated here by this arrow. So in order for Estonia, the policymaker in Estonia, which is actually the Estonian Health Insurance Fund, the primary guideline, both offerer as well, developer, as well as agency that reimburses, obviously, they may be particularly interested in the considerations that the panel had around cost. They would be presented here. They can look at that and see whether or not they agree with these type of judgments for the relevant context. And then either say, this is what we're going to offer, or this is what we're not going to offer. So in summary, my 11 minutes are up. Implementation requires individualization and tailoring of information for the relevant target audience. The great evidence to decision frameworks through work of panels and decision makers allow a direct connection to some of these implementation tools that I've described here. They really connect evidence synthesis, not a focus of my presentation, but very happy to talk about this more, to the decision maker. And this then leads to aids for patients, clinicians, and policymakers that really allow implementation, I think, in faster approaches or with shorter turnaround than 17 years, which we learned from the old, Lau and Antman papers many, many years ago. Thank you very much.
Thank you, Holger. Very elegant demonstration of the fact that evidence has to be contextualized, and a mention of values. So when we are patients, or when we are clinicians, or when we are policymakers, we are making our decisions based on a set of values. And the values may not be the same. The risk-benefit analysis may not be the same across the three things. Certainly when I'm a patient, I make my decisions often based on things that aren't strictly clinical in nature. And I think as policymakers, we forget that sometimes. Joshua, come and share with us your thoughts.
Thank you so much, and thank you for having me here today. It's an honor to be part of this conference. It's a remarkable international group that's come together, and my thanks to the thoughtfulness and how this panel was put together, and to Tammy as well, who spent so much time. I've been asked today to talk a little bit about a specific program called Quality Standards that Health Quality Ontario has launched about 2 years ago now. And I'd like to use this opportunity to think a little bit around what we've learned in our first couple years. Before I do that, a few quick things. So one, I think the only sort of disclosure I should acknowledge is that my airfare and accommodations were paid for by Cadith, so thanks for having me. And so if I say that they're the best organization in Canada with the best looking CEO I've ever seen, you know, it's just an accident. Ruggedly good looking, we say in our health. Yeah, that's Brian. I'd like to recommend a little homework reading, just because I got recommended. I'll introduce him more formally in a minute. When I got on this panel, I wrote to my VP, Irfan Dalla, who actually should be up here instead of me, and also ruggedly good looking. And I said, listen, do you have a couple slides you could send me? Just, save me some time, 7 or 8 slides. I got 12 minutes. He said, you know what you should do? You should read a book. I was like, not quite what I was after. He said, I actually have the book, but my wife's reading it, so you can't have my version. But if you go on Amazon, you have just enough time. And actually, to his credit, it is a fantastic book. And so it is How to Implement Evidence-Based Healthcare by Tricia Greenhall. And I'm actually going to use it as a foundational framework for much of my talk, and it is an exceptional read, and it is deceivingly short. It's one of those you'll have to keep going back to. One caveat, I guess, I just always feel, I'm a family doctor, I'm the CEO, but unlike many of the people on this stage, I am not like an HTAi guru. That's why I have super smart people like Vivian, Nancy, and Irfan sitting at the back at HQO. So if there's really technical questions, you will see me quickly tag teaming to the three of them during the Q&A. And so I would just like to recognize Vivian, Nancy, and Irfan. They are three phenomenal leaders in HTAi in Ontario's healthcare system. Nancy, I know, gave a great talk yesterday, and we make a great team, and they're the heart and soul of our HTAi program in Ontario. So thanks for being here, and thanks for all you do in Ontario and HTAs. I also just want to sort of pivot a little bit, or not pivot, but just sort of as I move into the core of this talk, go back to sort of your opening comment. I loved how you had the patients and the clinicians stand up and acknowledge that that's where this all becomes real. And, you know, the theme of this conference is knowledge to action. But what's interesting is Health Quality Ontario, which I'll tell you a little bit about in just a minute, is actually created under a legislative structure and a piece of legislation called Excellent Care for All. And I guess what I'd like to challenge you a little bit today is to think about knowledge to action for all. So let me tell you what my Monday afternoon and evening look like. On Monday afternoon, I work in a huge academic health science center. I work in a huge primary care practice. I've got super smart quality improvement specialists with a big team. I got a souped up EMR with a dashboard. I got all sorts of flags and triggers going off to remind me about smoking cessation and all sorts of good things like that. I've got an interprofessional team with chiropodists and dietitian and social workers. I got a security guard right outside my door. I've got, it matters in my practice. I've got rapid access to specialists of every dimension, shape, and quality and quantity you could talk about. I got lab and ultrasound on my floor, and for MRI, it's just at our base hospital with everything integrated. And in the afternoon, I'll see a white male English-speaking pensioner with borderline hypertension who comes in, who's Googled everything about his inguinal hernia, including clinical trials for his routine hernia, and we'll have a nice educated conversation about his care. And I'm pretty excited about getting to knowledge to action for him. At around 5 to 5:30, I bike a little over 1 kilometer away. No angina, no chest pain, it's good, it's just 1 kilometer. And I arrive at a clinic that actually is closer to the academic center than even my primary care practice. It is literally across the street. And when I got off 2 Monday nights ago, as I got off the elevator on the 4th floor, there was actually a patient in active withdrawal because he'd gotten out of jail that morning, and actually in jail he had access to every opioid and cocaine and amphetamine he had any interest in. He was now withdrawing. He was completely disheveled. He had urinated in our foyer, and he had bipolar. He was there to see me about multiple benzodiazepines and opioid use. There is no security there, so when he escalated and got violent, it was just me, the nurse, and the secretary. And waiting in the waiting room outside the foyer, watching all of this go down, me and my bike helmet on my bike, and him in acute withdrawal, yelling immediately for benzodiazepines and opioids, were 5 new Canadians, all refugees from different parts of the world, almost none of whom spoke English, all of whom did not have documentation, all of whom worry about being deported. This individual deeply worried about going back to jail. That's my evening clinic. No dashboard, no EMR, no fancy QI specialist, no security guard, no social work. Knowledge to action for those people is just as important, but it is a completely different context. And I'm the same family doctor 1.5 kilometers away and 15-minute bike ride away. And yet both of those deserve knowledge to action of the best available evidence. So how do we collectively meet that commitment to our community? So what is Health Quality in Ontario? We are a provincial funded agency. We are a creature of statute. And what makes us a bit different from every other agency or quality agency, certainly in Canada and in fact globally, is we've been given sort of this interesting combined mandate. So we've got our HTAi and standard shop with super smart ClinEpi people and health economists and all the people that this group is so familiar with. But we also have a measurement and performance shop that does public reporting, performance reporting, sort of like CIHI, which many of you know. And so we have a huge website with performance reporting. We do private reporting or practice level reporting. We do system level reporting. And then down the hall, we also have an entire QI shop, an equality improvement shop. With all the lean specialists and the Six Sigma specialists. And so all housed within one legislative entity or agency, we actually have what does the evidence look like, how do we try to create change in the system, and how do we actually measure our impact and report on the impact of our efforts to improve the system based on evidence. And it is quite a unique structure to have all three of those completely in depth under one shop. And what we decided to use a couple years ago, and this, to be clear, was actually Irfan's idea. He read our legislation and said, we're supposed to be developing standards. And he had actually spent some time with NICE. I understand there's some NICE folks in the room. I mean, you're all nice, don't get me wrong. But as an organization, NICE in the UK, and he said, you know what, that is a pretty impressive organization and these standards work. What if we tried to do what they do in terms of creating standards, but let's go further? Because we have an opportunity here at Health Quality Ontario to not only make the clinical guide statements that NICE so famously does and we learn so much about. In fact, we sent some folks over to learn from them. But why don't we also think about how do we use our performance reporting to develop an information and data brief and to publicly report on our standards? And how do we make recommendations for implementation or recommendations for adoption to actually say, okay, how do we take these statements and as an organization lean into the process of making sure that it actually get used at the front lines? And how do we do all this with and for the patients? And so we actually, for each of our statements, also create a parallel one-pager of a patient guide. And so what we've done is we don't talk about a standard. What we talk about is our program of standards, because our program has the implementation, the public reporting, and the evidence-based standards. And we try to bring it all under one roof into a cohesive package. And that's what I've been asked to talk about today, is this program, this very unique program of using the best available evidence with our sort of team. We've created a whole new standards team to sort of look at the evidence and build it, to deal with our QI shop for the adoption, and then our measuring and reporting shop to actually say, are we moving the needle? How will we know? Both as individual clinicians or an entity or a primary care practice, but also at the regional level or provincial level, and with that public performance. And so it was a really good chance when I was asked by Tammy to sort of say, could you talk about this unique setup you got going, and how is it working? And what I decided to do for the remainder of the talk, the next 40 or 50 minutes, is to, I'm just kidding, just seeing if our chair's engaged, and deeply worried, is to actually try to close this gap. Because here we are doing something that's sort of innovative. We got this standards program that we're going to run out. We got 5 or 6 of us sort of having a beer now and then saying, this is awesome, this is awesome. And then we got a few early adopters holding up their hand and saying, yeah, I'm all in. We got volunteers, we got people coming out of the woodwork. But now we've got this really, really, really hard problem of moving the rest of the healthcare system along, from the minister's office right down to frontline clinicians and patients receiving care. And this is really, for us, this is the holy grail. This is the Gordian knot. This is the Cleveland Cavaliers 2 games down against the best team ever, of moving the rest of the healthcare system along. It's a basketball reference for our international crowd. The question is, how are we doing? How are we doing at using the evidence around implementation to cross this chasm into broad spread adoption of our quality standards? And if you go back to Trisha's book, I sort of say that now I've read her book, we're like buddies. Trisha and I, her book and I, she outlines these things that we need to do. These are the things where there's evidence that if you're actually going to have good adoption, these are the types of things that you need to do to implement our standard, or to implement HTAi. So I'd say in a few areas we're doing fairly poorly. So she talks about the importance of technology and citizenship engagement. And we actually don't build apps, we don't build websites. And in fact, in her book, she speaks clearly that in fact the evidence around how to build a good app and actually get it used is pretty poor and highly resource intensive, and to be cautious. And so whether we've been thoughtfully cautious because the evidence is poor or we just haven't had time to do it can remain unspoken, but we have not done a lot on really using technology to adopt our standards, nor have we done a lot in using broad layperson engagement. And I know the HTAi community has got a white paper sort of going into the details of who's a citizen and who's a patient and who's a clinician and what does the term mean. She's got a nice effort to delineate that in her book. We do not do broad lay public engagement on the development or implementation of our standards. So not so awesome. But I think both really important, although the evidence base, as she would point out, about how to really do this effectively is unclear. Where I think we've done, again, not much better is in using networks. And in her book, she talks a lot about especially soft networks, informal networks, not hierarchical networks, not traditional networks of CEO, VP, EVP, but those really soft networks that evolve of saying, and where she turns to is the patient community, where people are creating these informal networks to really drive things along. And again, where I think we have had most success in our standards program is when we've reached out and tapped into networks. So when we developed a standard on palliative care, we turned to implementation to the Ontario Palliative Care Network. When we did things in preventative in child women's health, we turned to the provincial child maternal health sort of committee and network. So we turned to existing networks to actually do the heavy lifting because they have the credibility, the resources, the presence on the front line. So where we have had, I think, a better chance of implementation success is when we use networks. Same with organization. She talks about the need for soft organizational, non-hierarchical power. And again, we really struggle as a provincial entity and a small provincial entity in the size of Ontario to really engage and enable organizations to really absorb this. And she talks about the importance of organizations having slack to be able to take in new evidence. And organizations in healthcare right now in Ontario, they do not have slack. In fact, there are front page headlines almost weekly, in fact, multiple times a week sometimes, about the lack of slack. So we are running in with this great, woohoo, we've got standards, and people going, we're at 115% capacity. But thank you. So it's always good to have the government. We're here to help, right? So how do we bridge that gap between organizations that are at the max, that are extremely hierarchical, coming in with new evidence? Where I think we've been doing a little bit better is in groups and teams and building leadership and reaching out to frontline clinicians and building interactive processes and a really good process to try to involve people in the development and ultimately the implementation of our standards. We've done a good job, at least in the creation of our standards programs, in involving patients. I worry a bit about the diversity. Where I don't think we've done a good job, and we need to turn to our networks and our organizations, is involving patients in the actual implementation. So I think the development, I think we can give ourselves a good solid B, maybe a B plus even. But when it comes to the actual implementation and asking networks and organizations to really bring in those patients to implement these standards, we're not performing as well. And it is so important because I can tell you in my own super fancy practice with all the QI resources, when I get feedback from my patients saying, you know, you're super awesome and you wear a tie, it's really cool. There's actually some article on that Irfan tweeted out that said I should wear a tie. What was it? It was BMJ? No, where was it? It was just out 2 days ago. It's very important dress study. But where we don't have them involved as patients, but when my patients give me feedback through surveys that I run late all the time, I pay attention to that. When they give me feedback and other things, that implementation of evidence is really, really important, and we're not there yet. What she talks about, and this is not what I thought she'd talk about for a book on how to implement evidence-based healthcare, what she talks about in terms of implementing evidence is actually simple stuff. Blogs, Twitter, language that's accessible to people, language that's culturally relevant to people. And we actually do a pretty good job of trying to turn our standards, you saw the pretty graphics, of trying to make our standards quite accessible to multiple audiences. We put blogs out, we tweet them out, we get very dedicated stuff for our Minister of Health, we get dedicated stuff for our deputies, we reach out, we get dedicated stuff for patients and for clinicians. And so we've really tried to make sure our standards have the right communication framework, which is what she talks about as being so important for evidence. Oh, shoot, that's backwards. We're not going backwards. So very quickly, where I want to end is where she talks about two final things, which are policy and systems. And we have actually spent a ton of time in launching our standards program with the minister's office and the deputy minister's office. And we spent a ton of time taking what we knew worked in NICE, but making sure why the Minister of Health had a value and appreciation for our standards based on what's on the front page of the paper that day and what the minister is going to get scrummed on right after question period. We have spent a ton of time repackaging all of our standards work to be aligned with their issues, with their priorities, and with the other data that they're getting in. Because as she points out in the book, these folks are inundated with data. Our standards are just one more data point, and it's our job to connect our evidence and our data to the other data that they're getting in, so it is a cohesive story. And we have spent huge amounts of time. In fact, we put the whole program on pause for essentially a month in a way, while we could sit down and address their anxiety about this whole program coming out from our agency so they could really understand it and see alignment. Same with our associate deputies, our assistant deputies. They really have to believe in this. They have to understand this. We spend time with CEOs and our regional health authority CEOs, making sure that the topics align, that they can connect the dots, and they can see how this is not something new and extra and oh my God, here comes HQO with something new, but actually here is something that's going to help them. Here is something that is the answer to the problem that they're getting pounded on each and every day. So we've spent a ton of time focusing on the policy alignment of our standards to the policy priorities and urgencies and agenda of our healthcare system leaders at all levels. And finally, where I think we all need to do a better job and our standards program struggles a bit, is this issue of systems. And we tend to think about the standards program as an entity in and of itself. And it's not. It's part of something bigger. It's part of a healthcare system. And as we bring it in, we're disrupting existing systems. And we've not always been mindful enough about how, however good our program is, it disrupts and changes the ecosystem that already exists there. We tend to treat our interventions in silos. And nothing in healthcare is a silo. Everything is connected in healthcare. So how do we do a better job at HQO of making sure that our systems of our programs and our standards that we're introducing are actually complementary and embedded in a very logical, complementary way to the existing systems and are not seen as disruptive or bumping, but actually an additive value. And so I think, again, she talks about, again, the evidence not being great, but at least being mindful of how your unique HTAi, or in our case, our program standards, lands into an existing web of tremendous complexity. And rather than just trying to sort of sever all those other webs and create a new standalone, it's got to actually interdigitate and weave in to that existing ecosystem. So we're excited, we're proud, but we have a ways to go. Thank you very much for the opportunity to be here.
Thank you, Joshua. I think you just heard an eloquent dissertation about patient sovereignty. And those of you who are familiar with the Scottish NHS Strategic Plan in Health will know what a pivotal part patient sovereignty plays in that. We ignore the patient at our peril in clinical care. And we must remember that we don't do things to patients as a health system. We work beside patients to meet their health needs, and there is a difference. Patients are the ultimate influencers of what happens in healthcare. You are the taxpayers, we are the taxpayers, you elect the governments. With that, Sally, may I ask you to come and talk with us, Please remember, Sally is a general practitioner.
Thank you, and thank you for having me. It's a great pleasure to be here in Vancouver. So, working with patients, I'm going to pick up on that theme. I'm a general practitioner in South Wales, and my practice, I suppose, is a little bit like the second example that Josh gave you. It's an ex-mining town with high levels of deprivation, and my job over the last 12 years in this practice has been to sit alongside my patients and help them make decisions about their healthcare in their own context. And over that time, there's also been an extremely large growth of evidence-based single disease clinical guidelines. And we heard quite a lot yesterday from Chris McCabe and John Brassey in their panel about the difficulties of decision-making in a single disease with a single drug and, with the evidence available. Can you imagine, as a general practitioner, in 10 minutes trying to navigate 4 similar decisions with a patient who has multiple comorbidities and trying to make sense of marrying up multiple single disease clinical guidelines? It's not easy. So I'm going to take you on a little bit of a journey back to the therapeutic relationship this morning, and also lob in a bit of a rant and a challenge at evidence-based medicine and see how we need to improve that and how we need to support patients and their healthcare practitioners in implementing evidence-based medicine in their context to meet their goals, not our goals, their goals. And also to talk a little bit about outcome measurement and patient outcome measurement. We heard quite a lot yesterday about real-world evidence and the challenges around collecting that evidence and using it. And I would argue that the best way we can do that is to engage patients and clinicians in that endeavour, because if they are really involved in collecting that information and using it at the coalface, you are going to have a much better data set later on to generate further evidence. So, why should we make the effort measuring patient-reported outcomes? This is my favourite quote from Voltaire. He said, "Doctors pour drugs of which they know little to cure diseases of which they know less into patients of whom they know nothing." And of course, evidence-based medicine has solved that problem completely, hasn't it? So, of course, we've made huge strides, haven't we? But I would still argue that we are all individuals. We all have a unique set of circumstances. We have unique DNA. We have unique comorbidities. We have unique situations at home. We are messy. And we need to have help with making decisions about our own healthcare. We need to be supported in making those good decisions that are evidence-based, but acknowledging that that evidence is not perfect, and we may not wish to take the evidence-based advice either. So how do we know? How do we work with patients better? We need to ask people their goals, but actually we can gain an awful lot of information by tracking outcome measures, because outcomes are not just about an endpoint for an individual. They give you a status as you go along, so you can track what is going on with a patient. And there are multiple applications of that, which we won't have time to go into today, but I've got a couple of examples to show you later on. So Voltaire, I show this quote every time I speak, because it never dies. So, to delve into that in a little bit more depth, evidence quality and applicability and the impact of clinical guidelines is really, really important. As we know, randomized controlled trials have been the gold standard probably for generating a lot of the evidence that we use in modern medicine today. But it comes with a real caveat, doesn't it? Because we're using ideal populations and then extrapolating that evidence to people who don't fit into that mold or maybe don't want to fit into that mold. And we have to take account of this. There are attacks on evidence-based medicine going on as we speak. This week in the United States, access, right to try for medicines. What does this mean? This is a real affront to evidence-based medicine, isn't it? And also it's an affront to the therapeutic relationship, because what do you do if somebody says, well, I have a right to try this, and you know in your heart that there is no evidence for that intervention, and that may cause harm to that individual in some way, but not just that individual, but all of the rest of the population that can't have something that is going to benefit them because you've spent that resource somewhere else. The opportunity cost of what we're doing. So, right to try, big threat, and it's up to all of us really to resist some of this that's going on, I think. Understanding and addressing unmet need. There is so much invisible unmet need out in the community, and we need to think about how we unearth some of that, because actually a lot of what we measure reassures us that we're doing rather well. But just because something is silent doesn't mean it's good. So I know that there's a lot of patients that are registered with my practice that are not getting a good service from my practice or are not getting good outcomes, and that's because they're maybe not able to access healthcare in the same way or tell me what their need is. So we need to understand need much better and address it. Understanding the context, the patient goals and choices. My goals are different to your goals. My context is different to your context. So we need to understand whether we are meeting patients' goals or not. And that really taps into variation as well, whether it's warranted or unwarranted variation. How do you know if something is warranted variation unless you are asking your patients and recording that? Knowing when to stop. So as physicians, and personally I've had a lot to do with medicines optimization over the years. How do you know when to stop a medication? How do you deprescribe? How do you know when to switch off an implantable device? We're really, really good at starting stuff as physicians, and we are really bad at stopping stuff. And we are causing harm by doing that. So how do we get into that really virtuous cycle of implementing but also de-implementing, and that has outcome benefits but it also has economic benefits and value for individuals and populations. And then all of this feeds back into trust, doesn't it, and the changing physician-patient relationship, or any relationship, any therapeutic relationship. And this needs to continue to become much more equal, with the power balance becoming much more equal, patients having the ability to create their own evidence and their own information and their own decisions about their healthcare. So that's my rant. Over. Nearly over. And I think there's a growing recognition in many spheres about, there's something not quite right here and what can we do about it. And in Wales, we've had prudent healthcare. In Scotland, realistic medicine. I know in Canada there's choosing wisely, there's less is more medicine. In Italy they have slow medicine, because that's very Italian, and kind of goes with slow food and things like that. But the point is there's a global recognition that we need to change this relationship and think about medicine differently. And a lot of that boils down to that co-production in the therapeutic relationship. But how do we know when we're prudent? How do we know when we're realistic? How do we know that we're having that right relationship in the therapeutic context? We do need to measure something. What's the delivery mechanism here? And that's when I became interested in value-based healthcare. And of course, outcome measurement is a central pillar of value-based healthcare. I've put the logo for ICHOM up there because ICHOM are the International Consortium for Healthcare Outcomes Measurement, and if you're going to get interested in measuring standard sets of outcome measures, including patient-reported outcome measures for patients, they are a good place to start. And they have a role in building consensus around what to measure, because we do need some standards if we're going to be comparing internationally. But they also support organisations with capacity building to measure outcomes, because, why haven't we done this already? Well, it's hard. It's hard, right? This isn't the way we normally operate. So it is a bit of a change management program to build this into normal workflow. So a little bit then about I hope I can go back. There we are, trigger happy. So how are you going to do this? I heard a lot yesterday about the real difficulties of generating real-world data, and this is an example of that, isn't it? And we've had difficulties with not having the IT, but also, quite frankly, it's difficult to build it into workflow. You know, are you going to collect this information remotely or face-to-face in a clinic? How are you going to do it? And fundamentally, I think that the way we need to generate this real-world data is, first of all, to really nail that communication between physician and patient so that each feels that this data collection is meaningful, it is integral to their direct care, it is a two-way thing, that both are able to see and use that information, that you're minimizing the burden of measurement, and that it is as seamless as possible with the normal way that patients and physicians are interacting. If you can build outcome measurement into direct care, which I believe you can, then everything else comes after that, because patients and their physicians don't feel that data is going off into a black hole, and there is an awful lot of data that goes off into a black hole, as we all know. So how do we do it? Well, in Wales, we've been very fortunate. We've had some excellent leadership, multidisciplinary leadership from the finance community, from medical directors, and now from Welsh Government to begin to allow us to do some of this. We've had some early intervention with ITROM to support change, and that was really around capacity building within the organisations to start to build outcome measurement into workflow. And then that really began to touch on the digital health space as well, because obviously some of this you want to be doing remotely via smartphones and things like that. So you start to be able to manipulate care processes as well as part of that work. It is possible to embed this in normal practice. With a period of short, intense help, you can embed outcomes capture in an outpatient clinic within 12 weeks. If you are doing a more complicated piece of work, it takes a little bit longer, particularly if you're using digital technology. But face-to-face, if you support clinicians and patients well enough in the beginning, this is perfectly possible, and you can scale it up. And the focus needs to be on raising the response rates to patient-reported outcome questionnaires and also the accuracy and validity of what you're getting through. But the key thing is that patients and clinicians need to see that information and use it. Here's an example. We began in Parkinson's disease, and we now have 100% data capture for patient-reported outcomes in Parkinson's disease. And this has been going for 2 years now and covers about 600 patients. So this was the first cut of data a little while ago. And it was using the ITROM standard set for Parkinson's disease. And very quickly, we noticed that the patients in that clinic were divided into 3 broad groups. Patients with new diagnosis, patients on maintenance therapy and fairly stable, and then those with very complex needs. And the humbling thing for me was we were treating everybody exactly the same. They were all having a 10-minute appointment, they had the same burden of coming to the hospital, but we were not meeting their needs in a flexible way. So we were able to start looking at addressing that. How else can you use the data? Well, the diagram in the top right there shows how you might track symptoms at an individual level and see a change over time, which might be linked to a medication change or some other intervention. And the diagram in the bottom right, I'm speeding up slightly because I can see the clock, is aggregated data from all of the patients against non-motor symptoms in Parkinson's disease. And you can see their variation, obviously, between the 3 groups, new, maintenance, and complex patients. The point being that you get a really granular needs assessment for your whole population, and you can then do service planning to meet those needs and get better outcomes. That's the aim. And there are many, many other examples. So to finish, I couldn't leave you without putting up a map of Wales, so forgive my indulgence there, but you'll notice that all the healthcare facilities are around the outside. So what's going on in the middle? Well, the middle is sheep, So I know you can relate to that, Anne. Yeah, coming from New Zealand. And this is the back of my house, so again, forgive the indulgence, but this is Wales. What patients tell us, and we have a lot of patient focus groups now working on this with us, what people tell us is this can and should be done. In fact, why aren't you doing it already, is what people say repeatedly. Going back to Joss's point, driving consensus through the clinical networks and patient groups, use people on the ground who are immersed in this. You know, they know what to do, they just need to be enabled. So using the networks, really, really important. Make use of people like ICHOM and start small. You know, don't wait for perfect. I think someone said yesterday, perfect is the enemy of the good. Yes, it is. Let's just start small and carry on. Focus on direct care. If we get direct care right and that relationship between patients, physicians and their data, everything else falls into place. But also pay close attention to the analytics you may need at the start, both locally and at a national level. But this is very, very doable. I think if you take this approach, we can start to, over time, build really credible real-world data that is direct from patients, linked to their care, and accessible for all. And that's all I'm going to say. But we can pick up some more in the session this afternoon if you want some more detail. Thank you.
Thank you ever so much, Sally. That was spectacular and quite thought-provoking. I picked one thing out of that, and that was slow medicine. I really like it. As a practicing paediatric surgeon, I love all the whiz-bang, very expensive toys and new lots of evidence that you push at me. But one of the hardest things I've had to learn through my 35 years of practice is to sit on my hands. And in clinical care, a lot of problems are solved with no intervention or very minor intervention. And although I love the toys, they don't always help the patients that I serve. I think we've heard some wonderful presentations, and we're now going to spend the last 10 minutes hearing from you. And while you amass yourselves at the microphones and come up with your questions, I'm going to pose one question to the panel. And that is, you've given us wonderful examples of how we can help patient populations. As policymakers and decision makers collectively, where should we be investing our efforts? We hear a lot about the things we can do in expensive secondary care. And I know across many governments and jurisdictions there's an imbalance between the investment in primary care and prevention versus the investment in secondary care. Talk to us a little about that. Sally, you're nodding. I think the microphones are on.
Yes, this is a subject close to my heart, obviously, as a GP. There's a lot of low-value stuff that still goes on. We talked about 17 years to implement new evidence, but we're equally poor at de-implementation for things that don't work. We're not very good at investing in prevention. We have healthcare systems that are increasingly sucking up so much resource that they're taking resource away from the things that create health and well-being. So we have to address this. It's very difficult because the system is so fragmented. But one of the things that we've been trying in Wales is to take a sort of population approach, for example, in respiratory care, and use the networks to create a cycle of investment and disinvestment, moving from low value to high value across the system. Everybody needs to be involved in that, all stakeholders. It's very difficult, but I think we have to get into that.
Holger?
Along these lines, and to support the point, it's related to it. I think health literacy is a key issue of our times, and initiatives like informed health choices headed by Andy Oxman, starting in elementary school to start educating kids, including underprivileged populations, about what it really means to undergo a healthcare intervention are critical in my view, and I think we're seeing changes in trends with regards to what we can do with appropriate healthcare information, and partnering with initiatives that provide key information to healthcare recipients or the general population is really, really key for this community and other communities that focus on evidence.
Can I ask Joel, I think you're still on the line, do you have a comment to make about this? No, I've lost Joel. Joshua.
Yeah, I'm here. I think I couldn't hear it very well, but I think I'll defer to the others on that question.
Joshua?
So I certainly agree, and again, probably have my bias given my clinical practice and discipline. I guess the one thing I had two quick, caveats though. One is I don't think it's an either or. I don't think we can just worry about putting more investments into public health and prevention and let our eye off the ball about reducing unwarranted variation in our acute care or something else. We have to be able, in a system as large, billions, tens, hundreds of billions of dollars, to be able to do two things at once. And the second caveat I have is that I don't think we can have I worry sometimes this conversation then gets skewed to, okay, well, let's just go talk to public health then, or let's go talk to primary care and leave the rest of the system alone. This should absolutely, there is no profession, be it a pediatric quaternary care surgeon or a community-based family doctor or anybody who can't find themselves in this conversation. So I think the prevention conversation and the population health needs to be an all-in conversation to be successful.
Yes, please. Is it Louise?
Know that.
Good morning.
Good morning, Louise Binder, Save Your Skin Foundation. I'm also a disciple of Porter and Teisberg's value-based health outcomes, and there's a group of us in Canada who've been actually trying to move this ahead. So my question, some of the barriers that we're finding, and I'm very interested in how we should solve them. One is we really don't have the right data and consistent and shared data and all the data stuff. Two, some of we have siloed budgets within our health system, and we're doomed, I think, as long as we have that. If you think not, then tell me how to fix that one. Let's be honest, there are many doctors, hospitals, and other of the usual suspects for whom the move from health outputs to health outcomes and being measured in that way and evaluated is very threatening. So how do we deal with all of those? I know we can, I just don't know how.
Yeah, they're all tough, aren't they? First one, what to measure and how to get some standards around that. I mentioned ICHOM, the International Consortium for Healthcare Outcomes Measurement. They're a good place to start. They cover, I think, about 50% of the disease burden now. But actually there's nothing really esoteric about the outcome measurement that ICHOM suggests. So you could, if there wasn't an outcome set, you could easily comprise your own, and generally it comprises what most clinicians would recognise as a national clinical registry type approach, plus a prom on top, usually. But getting that consensus with your local clinicians will be very, very important, and that can be challenging too. Siloed budgets, very, very difficult. Very difficult. I'm not familiar with the Canadian system, so I can't offer you a solution there, but it is something that policy is going to have to take account of for sure. Otherwise, it's going to be almost impossible to move resource where it's needed for best outcomes. And your last point was, sorry, I've forgotten your last point.
Vested interests.
Oh yeah. So That's a big issue, but I would refer you to Joss's nice diagram around the early adopters and then the chasm of failure, and start with the willing and move up, and eventually you do get some momentum around this. But trying to push on too many closed doors at the beginning is very demoralizing. So I would start with the ones that want to, and there will be plenty if you have a look.
Thank you. The gentleman, John, please introduce yourself.
John Gillespie from Medtronic in Australia. I'm a member of the Health Economics team. I've worked in HTAi for about 14 years. Really just a comment. I just wanted to share an example of this stuff in action from Australia. Our clinical practice guidelines for stroke management were updated and released in September last year. They're web-based. They use the GRADE approach. And what it enables is clinicians to look at it on their phone. I mean, I've got the guidelines, right here. And those guidelines are already being updated. They can update them recommendation by recommendation. So it's just a fantastic example of this stuff in action. I mean, the challenge is, of course, to make sure those guidelines are being implemented, but it's a great step in the right direction, and the Stroke Foundation in Australia are doing brilliant work.
Thank you.
Yeah, thank you. Lars Sandman from Sweden, ethicist. Thank you for an interesting presentation, but I have a comment on something I think I miss. I know we Swedes are very extreme in many ways, way up borderline people when it comes to the World Value Survey, etc. But I see an increasing demand for ethical analysis when it comes to implementing new methods in Sweden, where they see sort of the need to also get that in perspective. There's a lot of initiatives on setting up ethics councils that could guide when it comes to implementing new methods. We have a new process for national screening program that mandates an ethical analysis. Is it only we in Sweden that are extreme, or is that sort of an important part of the implementation process, an explicit part?
Thank you. Who wants to take that?
The answer is yes. I think it's a critical issue. Ethics have the considerations of ethics have a lot of implications. I think Sweden is probably going down the right road with having appropriate, hopefully not too bureaucratic approaches to doing this, but ethics influence conflicts of interest, they influence values, they influence health equity, so appropriate ways of making sure that ethics are being considered appropriately strikes me as a very reasonable thing to do. Not only in the context of research, I think you are relating to implementation.
Thank you. Last question.
Hello, I'm Marilla Marlowe, Programme Director from NICE in the UK. We've heard a number of examples of kind of essentially translation processes from HTAi decisions into implementation, and that's a very good thing, and some very interesting examples. We have examples locally in the UK whereby those translations have actually ended up becoming more restrictive to patients than the original intention or the original decision. So do you have any sort of comments or thoughts on how you prevent that kind of, actual kind of HTAi-based decision being kind of watered down or diluted in implementation? Or maybe you think it actually doesn't matter, perhaps it doesn't matter. I'd just be interested in your comments.
Thank you. Josh?
Sorry, I actually had a little bit of a hard time hearing the question. It was about HTAs getting watered down.
About the decision makers actually restricting the scope as opposed to adopting the scope recommended by the HTAi assessor.
I think, again, having worked as an assistant deputy minister for 5.5 years under 3 ministers and 2 deputies, I guess I have some sympathy for the worlds they live in, frankly, and the realities they view. And having spent a lot of time briefing a premier during those 5.5 years, their worlds are often more complex and more nuanced than sometimes we acknowledge. And I think in the book I referenced in the section on policy, she encourages us to try to understand. And it's hard sometimes to walk a mile in their shoes, so to speak, just like it's hard for us and impossible for us to walk a mile in the patient's shoes. But I think our job sometimes is to provide that fearless best advice, to recognize that this is also an iterative process. It's rarely a one crack at it. And so we may end up with a more scaled down or scope decision at one point, but that we should return to it and revisit it. The windows of opportunity change, the personalities change, the benefits and success from the first iteration change. So again, I think our job is to be compelling, to align ourselves to appropriately communicate the risk, but also just to recognize the complexity of that system environment. And again, when I talk about the system issues, the people issues, we really have to set our HTAs up for success. We can't just do the hard work, float them out there, and assume our brilliance will be duly recognized and just adopted wholeheartedly. There's months and months, often sometimes years of prep work that needs to be done to prepare and create the environment for adoption at the political levels to allow the broadest scope. I'm not suggesting this isn't something you're aware of. I don't mean to sound disrespectful in my answer, but I do think it's something to be, I think we sometimes forget just how hard those jobs are and why we see those constraints.
Thank you. I think that's a good illustration of context is everything, and we are in healthcare a team, and everybody needs to work together to deliver the right outcome at the right time, and outcomes have their time. Everything relates to context. On behalf of the panel, I'd like to thank everyone for inviting us, and for those in the audience for taking the time to share with us today. And I'd like to, on behalf of all of you, thank our experts for their wonderful contribution to this meeting. So please join with me.